Afternoon. Good afternoon. Welcome everyone for joining us for this seminar this afternoon. Today's seminar is entitled RADx in Our Region, Expanding Access to COVID Testing and Beyond. We have three panelists with us today, and these include Dr. Adam Atherly, the founding director of the Center for Health Services Research at the Larner College of Medicine at the University of Vermont, Dr. Kathleen Fairfield, a physician scientist and associate professor of medicine and public health and community medicine at MaineHealth, and Dr. Yvonne Jonk, a health economist and the deputy director of the Maine Rural Health Research Center at the University of Southern Maine. So RADx is an abbreviation that I didn't know before, and it is the Rapid Acceleration of Diagnostics Initiative developed by the NIH as a call for scientists and organizations to bring their innovative ideas for new COVID-19 testing approaches and strategies. RADx programs make it possible to rapidly scale up testing across the country and enhance access to those most in need. While diagnostic testing has long been a mainstay of public health, newer technologies offer patient and user-friendly designs that work with cell phones, for example, to lower cost and increase accessibility, both at home and at the point of care. The program has been hugely successful nationwide, and in this seminar, you'll hear about two projects within the NME CTR region, one conducted with marginalized rural constituents and the other in a more urban setting. So welcome so much to our panelists. Oh, and just as a point, administrative point, if you have questions, please feel free to put them in the chat or to raise your hand. I think we'll do questions at the end of all three talks. Thank you. Go ahead, Dr. Fairfield.
Thank you. Thank you, Jess. Hi, everybody. You know, a lot of the people on this call. And so I'll be speaking probably for about half an hour on behalf of our team. This is our title. We were really interested in factors influencing testing in these populations. I'm going to talk about those populations in more detail. I'm sorry, am I in presenter view? There we go. That's better. Our goals are to understand barriers to COVID testing in underserved populations, to develop messaging and aimed at encouraging testing, to provide walk-up testing at 3 weekly clinics in Portland, Maine, and to study a cohort of people participating in home testing to understand how that might work in these populations. As you probably all know, the NIH has made a $1.4 billion investment in innovation and implementation of COVID-19 testing, of which 500 million is focused in these underserved populations. That's the RADx up is for underserved populations. For this grant, we received $2.3 million of this investment to focus on COVID-19 testing in several vulnerable populations in Cumberland County. We have 4 key community partners who have really been the central to our success: Preble Street, the Greater Portland Health, the Portland Community Free Clinic, and Prosperity, Maine. This is a big study team, and it's really one of the reasons we've been so successful. We have some incredibly talented people. As you all know, Cliff Rosen is co-PI of the Northern New England CTR grant, along with Gary Stein, and officially PI on this grant. I'm the project lead, and Liz Jacobs, who is our VP for research, is the co-lead. We have fantastic program manager, Gloria Sklar, who's about to get her PhD. Our research associate, Ambia Ahmed, who is just terrific. She's a Somali physician. She matched in our pediatrics residency program. So she's going to retrain starting, today's her last day, in fact. We have a UNE med student taking a year off, Hina Hashmi Swapnika Malipeti, who's a UNE incoming med student. Grace Price, a family medicine physician who's a preventive medicine fellow. Anne Marie Hess, a nurse practitioner, also working on her PhD, who's an informaticist. A coordinator, Kathleen Walsh, who's rotated off. Kina Thacker, a infectious disease physician with a lot of experience working with people who inject drugs. Ellen Touchette, who's a superstar data analyst and data visualization person, who I've worked with actually in the past when we were collaborating with UVM on our overdose analyses. Mike Kohut and Nicole Hudak are qualitative researchers. Deanna Williams, REDCap expert. Deb Rothenberg, our physician lead at the Preble Street Collaborative, Learning Collaborative. Our research navigator, Melissa Graham, who helped us with all of the IRB materials. Don Lawler, homeless health nurse practitioner. And then several new incoming people, David Ngandu, who's a physician from the Congo, speaks 5 languages. He's our incoming research associate taking over for Ambia. Sumi Awale, who's a Somali woman who speaks in English and Somali, our incoming research assistant and coordinator. And then a summer intern, Daisy Parker, an undergraduate, and Lizzie Vinton, who's an MD MPH candidate. So they're both starting Monday. The background, as you probably all know, that socially vulnerable populations have higher rates of COVID infection and mortality to do with their occupations, their underlying comorbidities, crowding, et cetera. Testing is a really important tool, especially now that we have treatment. And community engaged research is really an ideal way to better understand how we can decrease these disparities. I'm going to quickly show you without, I'm sorry for reading my prior slides, quickly show you without reading them our aims, and then we'll dig deeper into each of the aims and what we've done so far. So aim 1, I'll just give you a moment to read that. So this is our qualitative component. Aim 2 is all about public health messaging, building directly on our qualitative findings. That was 2A. Aim 2B is all about walk-up COVID clinics to decrease barriers to access. And aim 3 is evaluating some of the impact of our messaging, but also trialing a home testing program with 150 people over a year. We were specifically interested in several populations. We have a diverse immigrant population in Portland and across Maine actually now. And so we selected the top 7 languages spoken, particularly those cared for by our key community partner, Greater Portland Health. So Somali, Spanish, Portuguese, French, Arabic, Lingala, and Kinyarwanda. We're also interested in people who are low income and may have difficulty accessing testing. And we are drawing from people accessing Portland Public Health Services. So the Portland Community Free Clinic, our STD clinic, and Needle Exchange are all housed under one roof at 39 Forest Ave, right downtown. And also people experiencing homelessness. This includes also people who access services at a teaching clinic called the Preble Street Learning Collaborative. That's a collaboration between Preble Street, which is a nonprofit entity, and MaineHealth. And also people who are part of a Housing First initiative. And there are people who are considered chronically homeless that have been now living in apartments with a lot of social services support with good success. And I'll explain in a minute why we particularly were interested in that population. A few words about our community partners, because they've really been central to everything that we've been able to accomplish. We had great buy-in from the beginning. These were people that I'd worked with professionally actually over decades, and I think that was really helpful. But also they really helped select people who could support us and had the time to support us. So great buy-in from the beginning. They were each asked to select somebody to attend twice monthly Zoom meetings. Those are now monthly, but we did for the first 6 months, every other week. We also asked them to select a senior leader to join a community and scientific advisory board that meets quarterly. And that's been just a critically important group of people, very knowledgeable. It also includes someone from Maine DHHS and a few other community agencies. Our community partners, we asked them to co-host these walk-up clinics that I was talking about at their physical location, to advertise for these, to help their patients understand why we might want them to get tested, et cetera, and also to provide a staff member to support us at each of those clinics. We also needed them to help us connect people with services if they did test positive, for unhoused people, transportation to a quarantine shelter and support. That's been a difficult problem and is actually now closed. We'll get into that a little bit when we talk about the qualitative findings. Connecting people with other supports made available through the state of Maine. There's help with grocery delivery, fuel assistance, other material needs that people might have. Now we also asked them to help us treat people who tested positive. So we had the medical directors all step up and make sure that we understood the emergency use authorization of Paxlovid and where it's employed and how to get it to our patients so that they didn't end up needing to go to the emergency room, for example, or a minute clinic, which turns out to be about $300. Our agreed upon stipend for our community partners was $20,000 per year for each of the 2 years of the grant. I already mentioned, I think, our partner names. So now I'm going to talk about how we operationalize these aims. So, oops, forgive me. Aim 1, I already said, is to understand patient perceptions of and fears about the experiences with COVID-19 testing in our populations. We recruited people through community partners. We aimed for 4 from each of the groups shown in table 1, and we supplemented these with 2 to 3 interviews from key informants, people who provide care for these populations. And so study 1 shows our study population. We were interested in these specific immigrant groups, and then the needle exchange, free clinic, SCD clinic, and the Preble Street Resource Center. I'm sharing our interview guide. I'm not going to go through all of this, but this is just so you can get a sense of the questions that we asked. Mike Kohut is our lead qualitative researcher. He's a PhD cultural anthropologist. He's really skilled at interviewing vulnerable populations. We start kind of generally about asking people's living situations, what they're doing with work, experiences with COVID, what they might do if they had COVID, where they could find their sources of information, which is fascinating, whether they were concerned about giving it to others, would they be able to isolate it, for example. Many of them live in multi-generational households if they're immigrants or are staying in shelters. This time there was a quarantine shelter, the Fairfield Inn, and a few other places where people were staying when we developed this last September. We asked them questions about if they wanted to get testing, how would they go about it? What if they didn't feel sick, but just were exposed, for example? People know about the Maine CDC, what were their impressions of that? If someone tested positive, would they be interested? Would it be useful for the CDC to know, for example? And then just a few questions about their age, gender, race, ethnicity, etc. These were all qualitative interviews were recorded. We had verbal informed consent. They were all anonymous and they were professionally transcribed, and then they're analyzed in max QDA by three people who are doing created a code book and are doing all the coding, led by Mike Kohut, but also with Gloria Sklar and Hina Ashby, the medical student. So they conducted a thematic analysis to identify key barriers to COVID testing. We ended up with 26 key informant transcripts and 34 participant transcripts. We hadn't initially planned on having key informants, but we realized that partly because we had such disparate populations, it might be helpful to talk to some people who actually care for these populations. So we had some of the community health outreach workers called CHOWs. We had people who work in the needle exchange and people who work in the shelter system. It was incredible. They had incredible insights. We categorized these findings into barriers, which fell into 2 domains of health decision-making. One is the 5A model of theory of access related to, can I get tested? Accessibility. Is the testing accessible, acceptable, affordable, available, and accommodating to their needs? People didn't know, for example, where to get a test. Like, what if they didn't have any money? What if they couldn't get transportation? What if their language, they didn't feel supported with their language? And then, should I get tested? And this relates to behavior change theories, their perceptions about risk, attitudes, and social norms. So there were people who had, for example, very low risk perception, some conspiratorial thinking, which is fascinating, major consequences of testing positive. For example, people who don't have paid time off when they're ill couldn't find out, didn't want to find out if they had COVID, if they were going to miss work, maybe losing a spot at a shelter, feeling like if they had to go to a quarantine shelter that it felt a little bit like incarceration and they weren't going to be able to to go out and have their other needs met, including people who had substance use disorder and had specific substances that they really needed to take every day. The next aim is related to then taking what our findings in aim 1 and creating some community engaged messaging and understanding the problem and kind of what to do with all of those findings. So for this, we conducted some problem and solution tree work. We are conducting problem and solution tree workshops led by Gloria Sklar. We've had one to date, and we have another one scheduled for June. This is a participatory method used to develop public health programming. The tree is the root of the key of the public health problem, the root causes to the problem, and then potential intervention solutions are the leaves. Researchers and community stakeholders work together to generate the tree. This is a poster presented by Gloria for our in-house research meeting and this spring. And so this just gives you a kind of an overview of the poster itself. And I'm going to focus in on the graphic design for the problem tree. This gives you a little bit of a sense of how the workshops go. Inviting the community partners who participated in giving us the data for aim 1, especially key informants, to help talk about this. So again, at the trunk of the tree is the problem. People who are unhoused, which was the focus of the first problem solution tree workshop, may not get tested for COVID-19 when they have symptoms or were exposed because, and so each of these arrows goes to roots of the tree, and negative repercussions if positive, again, losing access to resources, going to a quarantine shelter where they not be able to access friends, substances of choice, etc. Not thinking testing is needed, even if they recognize COVID as a health risk. That frankly is a problem across all populations. Even now with some treatment available, testing fatigue, people had sort of, it seems to me there's a lot of differences or similarities, maybe both, with HIV testing. People sort of like, well, I was negative a couple times. Why do I need to keep testing? Why would I want to know? Not viewing COVID as a major health risk, competing priorities. A lot of the people who are unhoused and a lot of our immigrant populations really are focused on the day-to-day survival, staying warm, shelter, getting access to food, for the immigrants' work, being able to earn money so that they can buy groceries, etc. A lot of distrust in the medical system, which probably won't surprise anyone here. For the unhoused, certainly a lot of comorbid mental illness. Worries about the discomfort of testing. We all remember the mid-turbinate swabs. Those were very unpleasant, and people felt like that was a real barrier, and we're really, frankly, not willing to do it. And then difficulty accessing tests. Kind of where to get them if you don't have an address, don't speak English, transportation issues, etc. So we're still working on this part. As I said, we have done one problem solution tree workshop. It was incredibly valuable to hear, to go through this with our community partners and key informants, and then really to think about the solutions. And so, as I said, we have others planned for the immigrant populations, and then for the low-income populations and people who inject drugs and accessing public health services. We planned, we used Canvas for a lot of our educational programming, and it's a great place to put things where the curricular materials, we translated instruments into these 7 languages and support tools that our community partners can use. So we're standing up that now, and we're very proud of that. That's going to be one of our big activities for the next few months. Those will be available to our community partners, and then beyond that initial circle of the 4 community partners. We are also working on engagement, as I said, with more community partners, and we do plan to do a little bit of focus group work. That'll probably be a little bit more informal. We are also really thinking about succession planning and what happens at the end of this, and really wanted to make sure that we're working with our community partners to empower them to take care of the patients and people that they take care of. So I'm going to switch gears now and talk about aim 2B. That last one was aim 2A. Originally, those were together. Implementing low barrier COVID-19 walk-up testing clinics for vulnerable populations. So I should say who these people are. On the far left, Ambia Ahmed, in the middle, Swapnika Miley Petty, and then Hina Ashby on the right. And it really did look like this when we started in January in Maine, outside. So the walk-up clinics are all, as I said, outside in front of community partner sites, GPH, Greater Portland Health, the Community Free Clinic, and Preble Street. We did a lot of work designing our clinics and preparing, and under Gloria's leadership, we had site visits at each of our community partners, worked really closely with them to find out when they might have a staff member to support us, and also when they would have a little bit of foot traffic and people that coming by, because we, for example, at the free clinic, we started on Wednesday morning. It was just too early. People weren't really coming by at 9 in the morning. They didn't start coming until noon. So we had to, shift our timing. We had to train our team members to administer the rapid tests. That involved understanding CLIA and the rules, and understanding the different tests, and making sure that we had good documentation, all that. We have iPads that we use for data collection at these sites. And so we had to have iPads that had access. They'll have data plans, for example. We had to compile resources in the 7 languages. And I'll say this has been really well supported by RADx Up. We work really closely with an engagement team that is a Duke and UNC partnership, and they've translated all of our materials. We send them so much volume, it comes right back to us. It's fantastic. We had de-escalation training. So Preble Street, one of our community partners, recognized that because of the unhoused population risk of fears of working with healthcare workers, et cetera, maybe it would be a good idea to do this. So we did a training. It's hard to remember. I think it was in January. It was in Martin Luther King Day. And in fact, the very next day at one of our clinics, we had a patient who started to get really agitated about self-swabbing. And Hina Hashmi, the medical student, did a fantastic job settling the patient down and talking her through it and pulling her aside, et cetera. So a combination of having our community partners with us at these walk-up clinics and having a training so that our team really feels like they know what they're doing has been great. We started officially January 14th. They're very accessible. As I said, that was one of our key fundamental expectations. They're anonymous, so we had to work with both our funder and our IRB about this piece, because people are participating in a study. We wanted it to feel safe for them. We worked really carefully with our community partners so that if somebody did test positive, the community partner could collect their information and that needed to be reported to the Maine CDC, for example, and now connecting people with treatment. Of course, there's no cost. They can walk up. Now people know our team's going to be there, and at certain days of the week, and they know we have language proficiency. Ambia speaks Somali and Arabic, and then we have a study phone where we can call our language line. And of course, these sites are very trusted. Our workflow includes for each clinic having the team has everything stored at the community partner. So setting things up, consenting people. There's an initial intake survey where the staff is just asking why they're seeking testing that day and trying to figure out their language and which of the populations they're part of. They go through the testing process, and while they're waiting the 15 minutes for the test, we collect data, and these are all common data elements that are part of the expectation of RADx Up. If they get a positive result, as I said, the community partner collects the key information, reports that to the CDC. It's a red cap tool for Maine, and I suspect for Vermont too. And then we connect them to services, which we've done since the beginning, and now treatment as well. Whoops. Forgive me. Okay. We've been collecting some field reflections. The team, this one also includes, this picture also includes Caroline Fernandez, who's a community partner at Preble Street, and Grace Price, who's the preventive medicine fellow in the middle, and then Hina. So we understand the importance of building trust with our community partners and the patients, really looking at the testing patterns. When we started, things were still from the big surge in January, things were really busy, and then things kind of quieted down in February, March. Now things have picked back up again. Just really kind of streamlining our processes, making sure that patients understand all the resources in their own language, and connecting people to treatment, as I said. So far, we've administered 119 tests. That's fewer than we expected. We thought we might have up to 25 a week. I think there's a lot of testing that's become available in the community. And I think we're still really kind of getting there too. A little over 10% positivity so far. And people have varying reasons for wanting tests, but we also found that some people had COVID before. Some people had a recent close contact, and interestingly, we didn't really anticipate this in the beginning, but some people needed a test in order to seek bed at a shelter if they had cold symptoms like I do right now, or a medical appointment. People at the free clinic have accessing the free clinic for evening appointments with a volunteer physician or nurse practitioner. They couldn't be seen if they had upper respiratory symptoms, and so they needed a negative test, but some of them didn't have a test at home, couldn't afford a test. And now that Paxlovid has become more widely available, we brought together our medical directors along with Keena Thacker, our infectious disease physician, and an ID pharmacist. And we went through a workflow where we could connect all of our patients to ambulatory treatment. If they're very ill, we have a protocol for sending them to the emergency department. We haven't had that happen yet, actually. And we have treated, I think, 3 people so far. So it's not happening that frequently, but it's important. We felt it was really important to be able to connect people to treatment now that it's available. Our third and final aim is this cohort study. So this is our goal is to recruit 150 people from these populations and to understand how a home testing program might work and knowledge, attitudes, practices over time. So we have 22 recruited as of yesterday, 5 from these Housing First program related to the Preble Street group, 10 from low income and public services. So that's free clinic, needle exchange, and STD, and 7 from immigrant groups. And you might notice that for example, we didn't have Cambodia or Khmer in our languages, but we do have a really diverse population. So sometimes we're going to have to use a language line, but some of our immigrants who have been in Maine for decades speak English, Djibouti as well. Our design includes consent. That's assigned consent. This is not for this aim. This is of course not anonymous. We have all of their contact information. A survey on an iPad, including the common data elements, training to do home testing. And these are all antigen testing. A survey with a link to RADx every 2 weeks, and this evaluates their testing behavior, why they tested, why they might not have tested. A survey every 2 months. That's knowledge, attitudes, and then and practices, and mailed test material. So they get 10 tests every 2 months. And just this month, we're expanding our reach to our internal medicine clinic, and because we have a really diverse population groups there who are low income, and we really need to make sure that we recruit 150 people to reach our enrollment goals so that we can follow them for a whole year. This is just a fun picture of this is one of Gloria's ideas, to have a refrigerator magnet to help remind people that they're going to have these surveys. They do 6 surveys over a year, and so these are magnets translated into all of our languages. Kind of proud of these magnets. Okay, so many details. Everything has to be translated into 7 languages, and there's more, of course, like what to do if you have COVID, how to isolate, how to get services, all these things, so that people can take these away with them. Lots of issues surrounding testing for CLIA, as I mentioned, the emergency use authorization, making sure that we were really compliant with everything that RADx expected, and of course, and the Maine CDC too. Trainings, things like thinking about the test couldn't be below a certain temperature, so we kept them just inside, vestibules where we were working. And they can't, now that it's getting to be summer weather, they can't be above a certain temperature, so we'll be thinking about that. Space considerations. One of our community partners, Greater Portland Health, really has very little space. And so for us to do our AIM3 recruiting, for example, we really can only do that there in the early evening. But we have another community partner who's not one of our 4 initial ones, who actually is giving us a conference room to do some of our immigrant recruiting, which is going to be great. It's a place that most immigrants will be able to access through bus or walk-in. I mentioned Deanna Williams, our RADx expert. She worked really closely with our team and connecting the language modules. And so if anybody's doing this is just fascinating, including things that complexity to do with the Arabic module. We now are starting to have people who have been enrolled for a little while, and so what to do about missing surveys, reaching out to people, make sure that we have protocols for all of this. And then the unhoused groups, as I said, the Housing First sites have a lot of support services, and the enrollment actually was coordinated with their social work teams, and so our team went and spent quite a bit of time there recruiting people. Okay, a little bit of limitations and hand wringing on my part. I worry a little bit, but this was too broad a population. We didn't narrow in, including all these 7 different immigrant groups, and then we have a few others who we didn't necessarily say we were to exclude them, and so that's interesting. Defining a group by country of origin. We have a lot of Somali patients, for example, in Portland, who never lived in Somalia. They actually grew up in refugee camps in Kenya, but they're considered themselves Somali. They speak Somali. Or defining people by their language. We have a lot of people who speak different languages. They might speak French, but they might be from 3 or 4 different countries in Africa. Very wide range of acculturation. We have people who are, of course, very sophisticated, graduate degrees in their home country, and people who have very limited literacy. And then all kinds of issues with abilities and mental health diagnosis, substance use. Some of our patients at the free clinic are actually work 2 jobs. They're very sophisticated. They're fantastic. Actually, it's been a great source of recruiting for AIM-3. And then we have some groups that we're having trouble reaching. Some of our Latinx community in Portland, Maine area. A lot of them are undocumented. They also work really, really hard. And so they don't have a lot of spare time to be thinking about testing or participating in studies. People who inject drugs or who have opioid use disorder are also really challenging to take care of, to find and recruit for studies. We're trying to be sensitive to that. We're working, as I said, on our messaging for AIM-2 and working really closely with Maine DHHS and just thinking about who these people are that are most proximal to the communities we serve. It's very fast, rapid shifting landscape with different waves of COVID, testing, quarantine shelters seemed really important. It came up so much during our qualitative interviews. Now they're closed. And then sustainability, really thinking about what are we going to be leaving our communities with in September of next year when our funding ends. Just a couple of key takeaways, such important work in terms of decreasing disparities. We need to adapt. Sometimes we don't do that well. In research, we have to change our IRBs. We have to just, of course, document everything. We don't like to change in the middle of a protocol. Testing is information for people, and that's important. Now we have Paxlovid, oral treatment. We can reach these communities, but the community partners are the key to that. And we have a great, really fun and skilled team, as I mentioned. And I purposefully took the time to tell you who they were because it's really because of everybody on the team. So here they are again. I want to acknowledge the Maine DHHS. We've been working closely with Sharon McDonald, who leads our testing, and then our community partner staff who have been there with us at these testing clinics supporting us. And that's it for me. So I think we're going to wait and make sure that Adam and Yvonne have time and then do questions at the end.
Okay, so I guess I'll jump in. So Yvonne and I are just going to talk a little bit about the project that we've done. We're very early in our process. We formally started in January, although it was really more like mid-February before we actually got the notice of approval. So what we're going to do is just describe what we're planning to do. And Kathleen, by the way, fantastic presentation. And a lot of what you're doing has a lot of synergies with what we're going to do. So so what the project's really looking at is testing, just as in Kathleen's, but we're looking at a little different population because we're looking at rural populations. And what we're really interested in are the older, vulnerable rural populations who had potentially challenging access to testing because of location. We're working collaboratively with obviously with Maine and with Yvonne, who helped me write the whole darn thing. And then we're also working with the departments of health from both Vermont and Maine, and they're active participants with us in our project. And one of the ways I like to think about this project is, in some ways, the departments of health had to stand up testing in rural areas with absolutely no idea how to do it effectively. So they were trying to figure out what locations and timing and all these kinds of things, and there's just no evidence at all. And so one of the ways when I've spoken to them that I like to think about this project, and maybe they don't, but the way I like to think about it is, in some ways we're evaluating what was done, and and that's not at all there should never think about anything critical out of this, again, because they're operating with absolutely no evidence base about how to set up testing locations in rural areas, because there's just no precedent for anything like this. But now we have a precedent. So let's learn from what was done and try to see if there's a better way to do it. And also we have 3 aims. The first is to look at individual, community, and structural factors that predict higher or lower rates of COVID-19 testing in rural, underserved, and vulnerable populations. The second is to understand how the rural, underserved, and vulnerable populations make decisions about COVID-19 testing and identify optimal strategies to increase testing rates. And the third is to test the effect of targeted communications using a rural communication network to use optimal communication strategies. And Yvonne, do you want to say a little bit about aim 1, and then I'll talk a little about aim 2?
Sure. So aim 1 is really trying to identify populations that are at risk of either not obtaining testing in a timely way, and to identify populations that were successful in terms of getting tested. And so what we're doing is looking at the all-payer claims databases, both in Vermont and in Maine, and linking those with, in Maine, it's the CDC testing data, and then Vermont's testing data. And then looking at populations that are, stratifying it by rural locations. So we've talked about using the RUCA codes, looking at isolated small rural versus large rural. And so it's a very different focus than Kathleen's, but definitely a nice sort of complement to the work that she is doing. And so it's kind of exciting to see, the hard work that she's been doing in urban areas where we're planning on stratifying it, by levels of rural, and identifying, how far are people having to travel to get tested. Now, of course, once home testing came into play, that landscape changed. And so we were thinking that we would limit our analyses, at least in terms of identifying who was getting tested, to those people who obtained testing, and it was documented by the CDC. And home testing became available, I think, in the fall of, boy, everything's becoming a blur, right, guys? Fall of 2021? And so once that, change the landscape, I think that'll kind of put the brakes on us being able to link, the testing data with the all-payer claims database. But we'll still take a look, and we'll see what we have in the data and report that out. And so now I'll pass the baton to Adam. And did I miss anything, Adam?
No, just an absolutely great description of it. And again, we're just very lucky that the 2 states departments of health are willing to be cooperative of it, because when we put together this all-payer claims database, we're going to have data on essentially everybody in the state. And so we're going to have a couple million people, and we're going to know exactly who got tested and when. And so we're going to be able to then link testing locations and all these kinds of cool stuff using this quantitative data. And I'd be surprised if anybody else in the country had data like this and was able to answer questions like this, let alone, anywhere, let alone in rural areas. But what, Yvonne gave the great description of what we're doing quantitatively. But there may be, there's going to be some things that aren't in the data. So the all-payer claims database is fantastic in terms of its breadth and the detail and the accuracy. But there's a lot of things you can't learn from that kind of data. So the second aim, what we're going to do is we're actually going to go out and we're going to run focus groups in rural areas in both states. And we're going to talk to these rural populations and ask them about their decision process of getting tested or not. And we're going to look at areas that have relatively high rates of testing, There's a few areas that have quite low rates of testing. We're going to talk to older people. We're going to talk to working age people, kind of do a whole series of about 20 focus groups. And from that, hopefully, when we put these two pieces together, we can use the quantitative data to really understand things like location, distance, chronic illness, age, all insurance status. We can look at all those things. And then we put that with focus groups, and we'll be able to identify those barriers that you can't really readily identify from these secondary data sets. And then we're to put all that together, and then we're going to essentially design hypothetical testing strategies. And we're going to try to use it. We're going to do what's called a discrete choice experiment, where we're going to characterize people's testing decisions using the different attributes of testing, for example, privacy, distance, cost, all those different factors that might affect your choices. And we're going to run these hypothetical scenarios to these rural populations. And we're going to actually see what sorts of designs for testing will have higher or lower response rates. And then you put all that together, and we should have a pretty good idea on, at the end of that, on how to design a testing strategy to increase testing rates in rural populations. And really, we'll know the barriers, and we'll know how people, what the most promising strategies to overcome the barriers. And then we're going to, in the third aim, we're going to run a communication strategies, and we're going to try to do something good in terms of the health for the rural population using what we learned. And that's really, really vague. Do something good. That's because we don't quite know what the health concerns are going to be, say, next winter. And so what we're going to do is work with the two departments of health and understand what kind of health message they want to get out to rural communities, and then try to see if we can use these rural health communication networks through the NNECTR and see if we can actually make a difference in the health of the population. Okay, and I'll stop there and we'll turn it over for questions.
Thank you all so much. We're a relatively small group, so feel free to raise your hand or just unmute yourself if you have a question. If you'd like to put your question in the chat, that's fine too, and we can just read it for you. And we have about 15 minutes for questions. And while we're waiting for others to, oh, Yvonne, go for it.
So I have a question for Kathleen, and great presentation, Kathleen, and so excited about the work that you're doing. It's just so fun to hear of it. And Kathleen and our team had a chance to just connect and, you know, kind of compare notes as to what our strategies are. But that sustainability thing, what is your gut feeling? I mean, is it, you know, that you're developing toolkits, you know, that you can hand off to your community partners and that hopefully they can keep things going, but the funding piece of it that helped engage, you know, those stakeholders in the communities, that will be gone, but is that necessary? And so I'm just curious as to what you're thinking in terms of being able to continue your good work.
Yeah, thank you. Great question. We were sort of pleasantly surprised and worried a little when we first started that there was so much testing going on in the community. And so Sharon McDonald, who I mentioned, the CDC was doing, you know, like pop-up testing. They were working with a couple different agencies that connect with immigrants and doing some testing. We definitely had need and there was a little bit of testing happening at the shelters, but we definitely had need. And you know, in fact, the immigrant groups maybe were being reached a little bit better than the unhoused who were kind of outside of the shelters, et cetera, and then the kind of working low-income folks. So assuming, which I'm not sure this is a safe assumption, but assuming the state still has some resources to have testing available in these communities, it's there. I think, you know, Preble and the Learning Collaborative, the Free Clinic and the Greater Portland Health, and probably also at the hospital, having testing on site is hopefully going to be much more of a reality. We made it so special in the beginning, right? It was like so hard to get. You had to like drive up, and so people didn't have cars, and nobody wanted somebody with COVID like inside their walls. And so I feel like we really made it so difficult for the longest time. I feel like that hopefully a lot of that is getting better anyway. I think our community agencies, learning how to do it, learning how to train their team, store, have some tests on site, and is going to alleviate a lot of that problem. I think the other piece about the messaging and, people wanting to test if it's available to them is that's where we're going to spend a lot of our energy over the next year, making sure that we have our community agencies feeling like they have good, compelling reasons to encourage people to test. I was really hopeful actually about Paxlovid, access to treatment, because for a lot of people, they were like, well, why would I not want to know? Why would I want to know? It doesn't help me at all. And now that there's some treatment, I think it does help people. Unfortunately, you hear about the Paxlovid rebound, some of the rebound symptoms. That's, I think, discourage people a little bit, even though that doesn't happen, so often. And we know that it decreases the risk of hospitalization by 50% for people who are over 65 or 50 and above with comorbidities. So I think that, again, things will just evolve.
Yeah, and did the public health aspect of, knowing that you tested positive and then, following through with isolating, I mean, you mentioned, some barriers there, in terms of the population that you were working with, but, I would think that from a public health point of view, we need to get these strong messages out about the importance of testing and then subsequent action, around not, preventing the spread. And what's been your experience so far with that, Kathleen?
Well, again, I think it's such a mix. Some of the, the people who were unhoused, who were in quarantine hotels, if they were willing to do that, that was, once they got there, so many people were working really hard to make sure they had everything they needed in terms of food, and including the immigrant groups, food that was appropriate and to them, and social supports, etc. So I think, that's an opportunity, but I don't, now it's summer in Maine, right? So hotel rooms, we also have this huge influx of immigrants. As you've probably heard, the city of Portland's been housing about 1,700 people a night. And so I think being able to stay away from other people in your household, I'm sure everybody on this call has either had COVID or had someone in their household with COVID. It's not that easy. Even in a house with, separate bedrooms, people want to, move about a little bit. So I don't know the answer to that one. I think that's going to be one of the most difficult things with COVID in general is trying to get, it feels sort of inevitable to everybody at this point, right? People are going to get exposed, and some people are going to get it. And hopefully if they've been vaccinated, they won't become too ill.
Kathleen, with the program, having been in place now for, I guess, close to a year, and this is and I'm sure there isn't quantitative data, but is there a qualitative indication of increased confidence in COVID testing? And the second question I have, which is related to it, is has the messaging been evolving as you begin to see the extent to which you're getting engagement?
Just, I'll answer the first one. Has there been an increase in confidence in testing? I'm not sure. Sure that we'll be able to speak to that with the data that we have, because it was we only got our funding in early September, and all of our qualitative interviews happened pretty quickly because it was something that we could do. We knew it was going to take a little longer to set up the walk-up clinics. So all of those interviews happened in September and October. So we didn't it's not a longitudinal thing. However, from the cohort, we might have a sense from this, this year of participating in testing. I think now that it's not mid-turbinate testing, I think that helps. It's a lot less unpleasant. I think a lot of people are getting comfortable with the idea of testing before you go see your elderly relative, or before you, if you've been traveling and you're going to work or something like that. So I think there's been maybe a sea change there, and that'll be interesting. Can you repeat the second question, Gary?
Oh, you want full credit on the exam? Okay.
Yes, please.
I have to remember what the second question was. The second question was, with the program in place, for a period of time, has the messaging been evolving to go ahead and sort of building on experiences during the, the initial interactions with the clients?
Yeah. Yeah. Interesting. I do think it's been evolving. I think, again, in the beginning, it was this kind of quarantining, how can we get people to as far away as possible? Now I feel like everyone's a little bit more relaxed about it. Like, hey, it'd probably be good to know so that you're not in a shelter coughing, in close quarters. And you're not going to get whisked away to some place that you don't, it's not, you're not incarcerated. You're not going to be locked up with this. And feeling a little bit more supported. I still think, I think it's going to be one of our more important findings from all of the interviews that we did. This idea that the people who have so much precarity in their social situation, it's just not important to them. There's everything else is so much more important. Where they're going to sleep that night and what they're going to eat.
Just banking on what the question that Gary had, Kathleen, about the quality of the tests. The home tests, I've heard a lot of people who do get home, that use the home tests end up trying to go in for a real test, right? And so I'm curious as to whether you've run across that.
We actually had a big problem that, some of the immigrants and others were doing home tests or getting home tests, and then they thought they needed a confirmatory PCR, so they were going to the emergency department. And this is in January, in the worst of the Omicron surge. So in fact, how we got our first, if you all remember, in December and January, it was really difficult to get tests because everything was surging. We're having 800,000 cases a day in January. So we got some tests that were kind of like extras from our employee health that we're doing. We had kind of a 2-stage screening where people who needed to come to work but had a symptom were getting screened on the way into the parking garage. And then if that was, as long as they didn't have severe symptoms and needing a PCR and needing to go home. But they gave us some tests, and that helped a lot. And also we were able to spread the word through some of our community agencies that there was no need for a confirmatory test, so people didn't need to go to the ER. And in fact, it's terrible for so many reasons, right? If they didn't really have COVID, they could have caught it in the ER. If they had COVID, they could have given it to the person in the next chair in the ER. So I do feel like it's been helpful to have us in this complex mix, but as hopefully got the sense of, there's so many community agencies, so many people working on this, wanting to be really clear, and it's evolved so fast. I mean, it changes. Feels like it changes monthly, right? What the expectations are.
Something else I wonder about, if there are lessons learned in terms of encouraging screening beyond COVID, post-pandemic. Particularly with groups that might ordinarily not be taking advantage of screening.
Yeah. Yeah. Are you thinking not of like infectious disease screening?
I'm thinking of infectious disease. I'm thinking of cancer, things of that sort, because these are groups that may not really have, number one, they may not have encountered the healthcare system and and really had this available to them, or the education piece as well. So, part of it is education about COVID screening and its importance. And the other piece is the value of screening, the value of prevention. So it may open up a whole nother dimension to health and healthcare.
Yeah, wouldn't it be terrific? I mean, think about it. Now that everybody, we were just traveling, just how I got this cold. Now that everybody's so comfortable with it, you could do that during influenza season. And so you really shouldn't be visiting someone at the nursing home, at a long-term care facility with cold symptoms, but you could test for those kinds of things, for big gatherings, after going to a concert. People, we could train college kids to test for STDs on their own. These tests are so sophisticated. It's just terrific. And they're actually, reasonably inexpensive too. And people were already kind of doing that. Like, I'm sure you've all had friends text you pictures like, I'm not pregnant, but they're negative for COVID. People were doing this already for pregnancy or ovulation or things like that. And so it is kind of a fun thing to think about how this might impact our thoughts about just surveillance for infectious diseases for sure.
Sort of capturing the information secured in terms of how to work with these groups, and also it's capturing some of the effectiveness of some of these relationships.
Yeah. Oh yeah, that's another interesting layer. Who's people getting used to the idea of like this, not information testing results, negative or positive, is information. And they can have that information and they can own it, be responsible for it, and think about what they're going to do with the information.
I'm just jumping in because I don't see people raising their hands, but please, folks, raise your hand so that you can cut me off. But the other question I had for you, Kathleen, was, are we getting any better at figuring out when in the course of this disease you should test? Because I hear people testing day 1, day 2, day 3, like, when do I test? And it was negative the first day, but okay, maybe I should wait 3 more days. And and everything seems to vary by the variant. And so where are we with that? And have you tackled that in the course of trying to develop these toolkits and all of that? I haven't looked closely at your materials yet, Kathleen, so I don't know.
Yeah, I think it's very confusing, because it varies according to immunization status. And then it's varied according to variant. So no, we haven't gotten too far into that, other than that when people walk up, again, if they got exposed an hour ago or a day ago, we tell them to wait. And then also serial testing is the other piece. Like you had a big exposure or you have a symptom and you're negative, we want them to test again. And so that kind of messaging is important. But I think that's just going to keep changing. I don't know what's going to happen with all that.
Yeah, and a question that I would have for the broader audience is just, when we start looking at that data, there are camps such as USM for people who are not vaccinated. They have to be tested every week, right? And so we're going to see that in the data. And, that's going to kind of make it a little more challenging to sort out, the barriers and all of that stuff when it's a requirement. And I wonder how pervasive that is in the state of Maine. I don't have a good sense for that yet. What platforms are requiring that, people get tested? Anyone jump in?
Yeah.
I know it's, the university is one. I assume that healthcare workers are too, right?
We don't get tested in healthcare.
Okay, I'm astounded by that. Really?
I
required to be vaccinated, right? So this is really.
Yeah, but not boosted. We were not required to be boosted. What's interesting because, so many of the people who've had COVID have been vaccinated, right? So it doesn't have to do with whether you can spread it to someone else. I think that, it's confusing, but the reality is you can get COVID if you've had, just so that you're not going to get as sick. And so, we don't do like biosurveillance on all of our employees. I mean, remember in the worst of it, they were letting nurses come back to work sick. They were not, wow. They were just like barely recovered and coming back to work because we just didn't have enough staff. And so, no, we don't. I mean, my college kids got tested twice a week up at Bowdoin, PCR tested, which I frankly think is a waste of resources. But we were not tested as healthcare workers going into the hospital.
Well, my daughter's a CNA and she was required to get tested every week. Yep. How about the rest of you? Yeah, I don't know. Maybe that's just a nursing home requirement, right?
Yeah.
It just would be good to know that ahead of time when we start looking at the data, right? Yep.
Yeah, I had a question actually for you about, and it's one. It was just a question about the uninsured. I know not captured in the all payer data and what you thought you might do with the, is there any way to gather information about the uninsured rural populations and what's happening with them?
Well, we won't be able to merge them with the APCD. So that would be a pretty good indication, first of all, that they're uninsured, but we still have it on the CDC side. So that's a good question.
Right.
Have you thought about that, Adam?
Yeah, I mean, Vermont has a pretty low uninsurance rate as it is.
Yeah.
And so it's going to be, and in most of our target populations are going to be covered, especially older populations, they'll be on Medicare. So, but I'm looking at Jess and seeing like she wants to wrap it up, I'm guessing.
Yep, so we're over time, but this was a great discussion. Thank you so much, Dr. Fairfield, Dr. Jonk, Dr. Atherly for joining us. This was really informative.
Thanks very much.
Thanks.
Thank you
Nice to
so
see
much.
everybody.
Thanks for
Take
having
care.
us. Yep.